The article for presentation today is Prospective Comparison of Course of Disability in Antipsychotic Treated and Untreated Schizophrenic Patients in the Community Level. About the journal, this article was presented in Acta Psychiatrica Scandinavica, which is a Scandinavian peer-reviewed medical journal containing original and research systemic reviews relating to clinical psychiatry, started in 1926, and it is a monthly journal which is published by Willie Blackwell, located in United Kingdom, indexed in Web of Science, Scopus, PubMed Central, and Science Citation Index expanded, ranked 862 out of 27,955 journals. The impact factor of the journal in 2022 was 6.7 according to journal citation reports. The acceptance rate is around 15%, selective because of high number of admissions. The site score of the journal is 11.2. This particular article is accepted for publication in October 7, 2008 and published on 27th January 2009 in Acta Psychiatrica Scandinavica Volume 119, Issue 3. This article was cited by 47 articles. The authors of the articles are Jagadisha Thirthalli, Venkatesh, K.V. Kishore Kumar, Arunachala, Venkatesh Subramaniam, and Subha Krishnan Gangadhar, who are from Department of Psychiatry in NIMHANS and from Manasa Nursing Home, then and Department of Biostatistics from NIMHANS. Author information. Objective of the study: to compare the course of disability in schizophrenia patients receiving antipsychotic treatments and those who are not receiving in the rural community. Introduction. Schizophrenia is one of the 10 leading causes of long-term disability. Research and experience have shown that antipsychotics are effective against the symptoms of schizophrenia, and it also prevents us the further relapses. Evidence for the usefulness of antipsychotic in improving the functional status of schizophrenia patients remain low. Improving social and functional outcomes is also an important goal for psychiatrists in management of schizophrenia. There are so many cross-sectional studies have found that patients remaining untreated in the community experience greater disability than those on treatment with antipsychotics. Aim of the study is to examine the course of disability over a period of 1 year in 3 groups. The 3 groups are defined as already receiving antipsychotic treatment and continuing to receive it. The second group is not on treatment but started receiving antipsychotic during the follow-up time. The third group is not on treatment and remain untreated during the whole course of the study. Study method. It is a prospective study, which is a type of cohort study where a homogeneous group of people are enrolled and followed for a long period of time to determine the occurrence of death or disease or till the follow-up time occurs. It is a naturalistic follow-up study where no randomization was done and it is taken in the community, the same community setup. The study participants are recruited for the Community Intervention in Psychotic Disorders project in an administrative block of Thirthalli Taluk of Karnataka state in South India. 54 health workers, village health workers are trained to identify the patients with severe mental disorders in the community, and they were advised to refer the patients to the team irrespective of the treatment status, whether they are on treatment or not on treatment. Research psychiatrists have screened the patient using ICD-10 criteria and are diagnosed with the mini international neuropsychiatric interview. A total number of 258 patients were diagnosed having schizophrenia, and also a door-to-door survey is done in a randomly selected 10% of the villages for taking out the even missed out the cases. Identify 6 patients were missed out, and the total given estimated number of 60 patients were missed, which include 17.3%. All patients were offered treatment and follow-up in 1 year. The assessments they have used are Indian Disability Evaluation and Assessment Scale, which is used at both the time of baseline and follow-up. IDEAs have been originally designed for measuring and certifying the disability for psychiatric patients to get the monetary benefits. It has 4 domains: self-care, work, interpersonal relationship, communication, and understanding. The 4 domains are rated from 0 to 4, 0 with no disability and 4 of profound disability. The total gives the total disability score, which will be about 16. Intra-class correlation for the individual domains are ranged from 0.87 to 0.912. Inter-rater reliability was assessed for IDEAs by 15 patients who are not on the study were taken and they were administered IDEAs. And they have used a positive and negative syndrome scale to assess the psychopathology. Intra-class correlation for the 3 domains of positive, negative, and global domains were used in 8 videographed training interviews from 0.83 to 0.9, which is the intra-class correlation. The research psychiatrists were trained at NIMHANS to administer both IDEAs and PANS. This is the follow-up, where 258 patients were taken for the study at the first time. During the one year follow-up time, they found 215 patients. 22 were dropped out, which have 3 change of diagnosis, which include bipolar, alcohol dependence, and 16 withdrew the consent. Death 4 patients, untraceable 2 patients. Among this 215 patients, 190 were assessed with IDEAs, and the off-off group, which contains 33, on group contains 85, and off-on group contains 72. Only 11 persons in the off-off group and 70 persons in the on group and 60% in the off-on group have been administered PANS, because IDEAs can be administered with the help of the family members interview, but PANS was administered with the patient's interview. Few of the patients were not cooperative during PANS examination for detailed evaluation. Table which shows the sociodemographic details of the followed up and dropped out group. Followed group contains 190 patients and dropout group contains 22 patients. This shows no significance between them. Even if the dropped out patients were included, the change would have not, the study would not be much affected. This table shows demographic details and other details about the off-off group, on group, and off-on group. It shows significance only in IDEAs and total PANS score, which is less than 0.01 p-value. This is a flow chart where the patients who are advised treatment, 72 agreed for treatment and 46 remained untreated. 33 patients remained only gave consent for assessment. 13 refused both assessment and treatment. In 33 assessment people, 23 were unwilling for treatment. 6 persons were only concerned with medico-religious treatment and family members took them for medico-religious, and 4 had fear of side effects. In 157 patients treated, 141 patients, which is 90%, received atypical antipsychotics, which is risperidone or olanzapine. 12 patients, 7.6, received typical antipsychotics. 4 only received clozapine. The clozapine used was less because of repeated follow-up needed for the patient and repeated blood investigations. Regular treatment defined here in the study was for at least 2 months prior to the assessment period at both baseline and follow-up. The total disability score was taken as 7, which is 40% of the total disability score used as cutoff. Statistical analysis. ANOVA analysis of variance was used for continuous and chi-square test were used for discrete variables. Repeated measures of analysis of variance were used for as they had more than 2 groups. A McNemus chi-square test was used to compare the disability status at baseline and follow-up across the 3 groups of PANS. Pearson correlation coefficient was used to analyze the correlation between domains of psychopathology and total disability. The statistical package for social sciences version 10.0.1 was used for the analysis, statistical analysis. Ethics, the community intervention psychotic disorders project was approved by the Institutional Ethics Committee of NIMHANS. Written informed consent was obtained from all the patients and or from the members for treatment, follow-up and further assessments. This result shows the dotted line shows off-of group, continuous line shows on group, and the other line with shows off-on group. In self-care and in every domain, there are reduction for the disability in on group and off-on group. There is no bigger changes for off-of group. Even with the total disability scores, on group has a major reduction and even off-on group have major reduction. The disability remained same for the off-of group. Repeated measurements of ANOVA showed that there was a significant correlation with suggesting that disability has decreased across all 4 domains in the entire sample. Similar results were found according to the PANS in 3 domains. This is the table where it shows difference between the scores for off-on group and on group. This is the on group, which shows total disability from 5.6 to 2.58. In off-on group, it shows about 8.64 to 3.74, which is significant. This is for PANS. On group has 62.49 total scores and which reduced for 46.99 scores. In off-on groups also, there is a major difference. Across all the 3 groups, the 1-year PANS total score correlated positively with the 1-year total disability scores. The p-value was less than 0.01. Among the domains of psychopathology, the correlation was strongest between the negative syndromes and the disability scores was found. Discussion. The important findings in this studies, disability at baseline of the not receiving patients are more than the group which had treatment receiving patients. Those who continued and started receiving antipsychotics also had reduction in disability. This was apparent with the difference of disability in 4 domains and in total disability scores. Significance were observed for the psychopathological scores also. The study is consistent with the study by Etugral A and Ulag, influence of neurocognitive deficits and symptoms over disability. Disability correlated highly with severity of psychopathology. This study also, by having a comparative group of patients who remain untreated, establishes the association between antipsychotic treatment and disability reduction. This is consistent with another study which also had untreated patients in rural community in China, but that study did not have a comparative group to correlate. Studies by Srinivasa Murthy and Srinivasan also reported improvement in disability in schizophrenia patients following antipsychotic treatment. Disability remained virtually unchanged in those remaining untreated. With a rough estimate of prevalence of 2.6 per 1,000, the estimated number of schizophrenia patients living in India is 2.5 million. This is what quoted in 2008. It might the prevalence will be differing currently. Most of them are living in rural areas. In them, about 60% are still not receiving antipsychotics, and most have considerable disability. Critical appraisal. The topic significance is about discuss about substantial treatment gap in schizophrenia patients in the community setup. Highlights about association between treatment and disability reduction. Study design has a naturalistic prospective study which aids in disability assessment and has limitations in biases like randomization bias. Sample is taken from the rural community, which also resembles the majority of the schizophrenic population in India. Outcome measures. A study used validated scales like IDEAS and strength are they have a comparative treatment group for comparing the association between treated and untreated group. Limitations are generalizability. As it is done in rural community, it cannot be completely generalized to urban area. Did not formally assess cognitive functions. Types and doses of the antipsychotics are not controlled. It have not been mentioned. Ideas only have 4 domains, but it does not assess the other domains which might be needed in the social functioning of the patient, like getting around and participation in society, which is mentioned in UDAS, and so far as money management skills, instrumental skills, and recreation, leisure, real world functioning. It is not well clear of real world ideas are not well clear of real world functioning, like multidimensional scale of independent living and socially valued as role scale, classification scale. The confounding factors like alcohol, other substance use, organicity of the patient, other medical conditions, and the socio-demographic conditions of the patient, married, single, or having parents, was not assessed. Family support, attitude, and expressed emotions could have been different across the 3 groups. Bias they had blinding was not done. Overestimation can be seen in the off group, and underestimation of disabilities can be seen in other 2 groups. Funding. This project was funded by National Mental Health Program, Government of India's research grants to B.N. Gangadhar 2005 to 2007. I have used a Strobe checklist for a prospective study. This article mainly fills most of the criteria, and they haven't given eligibility criteria for the participants. They have taken participants from 3 months of the illness to 11 years of treatment illness. Bias was not addressed. Potential bias are not mentioned. Study size calculations like formula was not given in the study. Main results, there were no mention of confounders factors. No other analysis on the interactions between the other factors was not mentioned. Strobe checklist contains 22. Most of the checklists have been done. In title and abstract, they have given the indicated study design, where they are doing the study, in which community, background and objectives were given specifically. Study design was naturalistic, longitudinal, prospective study. Setting was described. Follow-up was done for 1 year, and follow-up details were given, how they have followed the patients, and follow-up flowchart was given. Data sources and measurements was done by ANOVA, RM ANOVA, and chi-square test. Quantitative variables was also given. Grouping, why the grouping was chosen and how the grouping was chosen. Number of participants at each study of the stage. Those who were even dropout was mentioned. The socio-demographic details was given. Outcome data was clearly noted down. Key results were summarized with the reference to study subject. Limitations was discussed. In this particular article, they have even given what could be done. They have even mentioned about the risperidone and olanzapine cost. They have discussed about 5-year plan of the risperidone antipsychotic treatment. Generalizability was given. Funding was given in the last slide. Thank you, sir.
Thank you, Doctor. So, if you look at where does our knowledge about mental illness comes from, only 6% of the literature is published from the regions of the world that account for over 90% of the global population. Right, most of the publication is from Americas and the Europe, where less than 10% of the global population stays. Only 6% of the literature comes from our part of the world where most people live, right? And there is a serious underrepresentation of the research from the rest of the world versus Euro-American countries. And very interesting observation by Dr. Vikram Patel was that there was not a single paper from India was quoted on a talk on management of schizophrenia in a national CME. So it was an Indian national CME and on management of schizophrenia, but not a single paper from India was presented, which was a major limitation of research in India. Most research happens in tertiary care, hospital-based communities, and most patients live in the community. So a lot of research comes from Europe and America, and even in India, it comes mostly from places like NIMHANS and PGI, JIPMER, AIMS, etc. But most patients live in rural areas and in the community. So if you look at where psychiatrists practice in India, nearly 70% of people live in the rural areas. Only 7% of the psychiatrists practice in rural area. So there is a small, minuscule proportion of research on mental health comes from settings where large populations of patients live. So this is the background with which we started studying patients in the rural cohort. So with that, I will go into the NIMHANS experience of treating patients in rural community cohorts. So the aim of the community cohorts is to provide uninterrupted services for persons with severe mental illness in rural communities. Most of them received pharmacotherapy. They also received what we call as low intensity psychosocial interventions by social workers, and the social workers were chosen from the rural communities where patients also lived. What they did was nothing but some ensuring of follow-up care to improve adherence, crisis intervention, working with families and communities for rehabilitation, and providing welfare benefits. We took a lot of help from the private practitioner, and among the 7% people who practice in rural areas, we caught one of them. So there was a private practitioner in this Thirthalli cohort. We took the help of Government of Karnataka and NGOs in all places, and varying levels of funding from different cohorts. I mean, for funding these cohorts. We have at least about 4 or 5 MD cases and 2 PhD students from NIMHANS worked on these cohorts. And research went in parallel with services. Our main aim was to provide services in these rural cohorts. We also use the data for research. And hence, we did not do many biological studies. We did mostly clinical and public health related studies. These are the places where we did our studies. These are the 3 talukas. This is Thirthalli, Turuvekere, and Jagadisha. There are these cohorts have been there for different years. About 600 patients with schizophrenia in total. We are following them up. We have asked the following questions. I will expand on this in our other slides. First question that we asked was answered today in the journal club. I will very quickly go through that. Why did we do this study? Is because many people were skeptical whether antipsychotics make a difference in the long term. Like these practice guidelines of treatment of patients with schizophrenia, these API guidelines said that there is scant evidence that medications improve functional status beyond achieved through the reduction of impairing positive symptoms. This came up repeatedly in our discussion today. Some have been very cautious. Long-term outcome of schizophrenia, antipsychotics perhaps help, but we need more studies to confirm. This was an editorial in BMJ at the time we started this cohort. Some editorials have been very scathing. The review reveals that this paradigm, that is long-term treatment with antipsychotics, worsens the long-term outcome. These were the views about whether we should treat patients with antipsychotics in the long run to improve their functionality at the time we started these studies. What I am trying to say is that people did not everybody believed that improvement in symptoms will result in improvement in disability as well. We looked at the disability at the time of recruitment. Some patients were on treatment, some patients were not on treatment. This is only at baseline. And we published this in the Indian Journal of Psychiatry, which showed that patients who were on treatment had less disability. Later, we followed up with this paper, which was discussed today, which about the results of which we have discussed. We also found out that people who were adherent to treatment were largely represented in the best outcome. This was a 4-year follow-up study. 4-year follow-up study, which we analyzed the different outcomes of 4-year study. A bunch of people had best outcome, a few had intermediate outcome, and some had worst outcome. You can see that people who are most adherent had best outcome, and intermediate had intermediate outcome, and people who are poor adherence had worst outcome. It could be the other way around also. It could be that people who had worst outcome stopped medicines. We do not know. It is difficult to say causality, attach any causality to this. What I want to stress is also that the outcome was meaningful to them. It is not just the data, it is not just the RMNOVAs and McNemar's tests that we talked about. We found that work functioning, that is a person contributing positively to the family's either income or work, improved from 40% at baseline to about 70% at the follow-up. Many patients who improved took the help of several government and non-governmental agencies for income generation activities. The improvements were meaningful for the family members too, because caregiver burden was found to be associated with disability, and as we saw, as the disability decreases, it is likely that caregiver burden also decreases. Coming to adverse effects, we looked at the metabolic syndrome. Prevalence of metabolic syndrome in these patients that we treated for many years in the community was about 10%. If you look at the prevalence of metabolic syndrome in other countries, it is as high as 60% and as low as about 22%. You could see that in a rural cohort, when patients are treated with antipsychotics, the risk of metabolic syndrome is not very high as we see in urban centers. In another cohort, we looked at, in this paper, we unfortunately lost the data of the general population. We wanted to compare the metabolic syndrome of people who are treated versus what happened in general population. We had an opportunity to do that in this paper. Drug-naive patients with schizophrenia had far less prevalence of metabolic syndrome than controls. What is well known in the West is that even drug-naive patients who are not on treatment with schizophrenia have more metabolic side effects or metabolic conditions than general population. But what we found in our population is that drug-naive patients in our population had significantly lesser prevalence of metabolic syndrome than controls. And when we did the follow-up, okay, 33% of the patients had metabolic syndrome. This is another cohort. The previous, this one was Thirthalli, this was in Thiruvekere. In this Thiruvekere sample, 33% had metabolic syndrome at baseline. It increased by only about 3% after 6 months. Again, here McNemar's chi-square was done because we compared the same cohort twice in terms of their percentage. McNemar test was not significant. That means after treatment for about 6 months, the rate of metabolic syndrome had not changed much. we looked at other side effects. So our patients were treated for a mean duration of about 14 years, and most of them initially were started on typical antipsychotics, and when we started the cohort, they started on atypical antipsychotics. The prevalence of tardive dyskinesia was about 40%. But if you look at carefully, this 40%, most of them had almost ignorable levels of negligible levels of tardive dyskinesia. Those who had moderate to severe PD were only 2.4% of the patients. So only about 5 patients had tardive dyskinesia, which was clinically meaningful. In the rest of them, since we applied a very sensitive tool, we found dyskinesia here, dyskinesia there, but the patient themselves were not aware that they had dyskinesia. So it was that mild. The severe, moderate to severe was only 5. So what we want to say is that there is a risk of tardive dyskinesia when you treat for long term, but our rural cohorts may not have a pandemic of tardive dyskinesia if you treat them for years together. We very interestingly, what we found about substance use comorbidities here. We compared 254 patients and 350 controls used in the past year and harmful use or hazardous use in the past year, according to the use of alcohol, was actually less in patients as compared to the controls. If you read all the textbooks, all of them suggest that substance use comorbidity is higher in schizophrenia patients than in general population. Very interestingly, in our cohort, we found the other way around. Patients with schizophrenia had less comorbidity with alcohol use disorder than general population. We feel that it may be because they don't have money to procure alcohol, because many of them have disability. So possibly we have also observed that many patients who improved with antipsychotics went on to have alcohol and then they relapsed. So when they become severely ill, it appears that at least in our cohort, their ability to procure alcohol comes down and they start using less. But this is a place where areca nut use is very high, betel nut, pan eating, without tobacco, only pan eating. That was higher among patients, and it was associated with some degree of no, there was no association with any symptoms, including negative symptoms. We had thought that it is associated with negative symptoms. Very interestingly, only one of the 256 patients with schizophrenia had use of cannabis. There were no other illicit substances. It is possible that it is an effect of where we are doing this study, where generally cannabis use is less. But we anecdotally know that many from the general population do use cannabis, but among our patient population, only one had ever used cannabis. We also looked at mortality rate. So the standardized mortality rate of our cohort was 1.77. SMR means to what degree patients with schizophrenia die more than the general population. It appears that patients with schizophrenia die more than general population by a multiplication factor of 1.77 or roughly double the rates. What you should understand is that the SMR, standardized mortality ratio, in Indian studies, which includes SCARF and this DOSMED studies and our study, all of them is about 2-fold increase in mortality among schizophrenia. Most of the studies from the West show that the mortality among patients with schizophrenia is far higher than the general population. So our patients with schizophrenia die relatively less compared to patients in the West. It may be associated with slightly less degree of substance use, and also the fact that most of them live with families and the families take care of their physical health as well. We also did a verbal autopsy of why people died. We had some interesting finding that a lot of patients had died of chronic kidney disease. Very small numbers to talk about. We can't say very confidently about whether this is a real issue or an incidental finding, but nevertheless, we found that many patients who died, a substantial number of them died because of chronic kidney disease. The rest of them are in 1122 numbers. Of course, we are not, these are non-suicidal deaths that we are talking about. Cost of care. You can see that before we went into one community, that is, this is Jagadisha cohort, they used to spend about 14,000 rupees per year for getting treatment. When we started doing our community intervention there, the cost to the patients came down to 500 rupees per annum for just travel by bus or some other means to the center. So it reduced a lot of their cost. We also looked at access and continuity of care. So we developed two instruments, one called Schedule of Factors Influencing Access to Psychiatric Treatment and Schedule of Factors Influencing Adherence to psychiatric treatment. So one is whether why patients remain untreated. The other one is to assess why patients stop treatment. So we had patients who were never took treatment. We interviewed them. We also saw patients who had taken treatment sometime and then never came back to the treatment. So with these two tools, Sophia and Sophia, we interviewed them, and these are the findings that we had. The reasons for never receiving treatment, most important was distance and transport related factors, their knowledge and attitude, financial problems, lack of insight, etc., etc. So these are the reasons why they dropped out of treatment. Again, distance, support and supervision of family members, financial factors, etc., etc. These may not be very surprising. What is really novel about these findings is that none of them had stopped or not accessed treatment only for one reason. In other words, not accessing treatment and not adhering to treatment are always multifactorial. On an average, we had 7 factors for patients who did not access treatment and 9 factors for dropping out of treatment. So when you talk about non-adherence, we should always keep in mind that it is not a single factor. It is a multiplicity of factors that play a role. If people are interested in using these tools, especially the Sophia, which looks at what makes people non-adherent, I will be more than happy to share that tool with you. You can use it for your clinical use when you see patients who are highly non-adherent. So reasons are complex. Each individual patient and family has their own signature pattern of factors. I will show you in this. So this was a never treated patient with, he had financial constraints, family dynamics and distance. Look at this patient who was also never treated. His set of problems were totally different. Lack of knowledge, lack of insight, family dynamics, gender, financial constraints and medical conditions. So both were untreated. The reasons for not treatment is very different. Similarly, this is a patient who was dropped out of the treatment. These were the reasons why they dropped out of treatment. And this is another patient who had a totally different set of reasons why they stopped. So there is not a one size fits all kind of approach to non-adherence. You should be always open to looking at it as a multifactorial challenge. So important lessons that we learned in the whole cohort was that in our entire study, social worker was an important key factor. So we ensured follow-up and adherence. We did not do much of rehabilitation. Families took care of most of the rehabilitation in these cases. And what we provided was low intensity psychosocial intervention. Now, these were all done in project mode. Can this be replicated in government setting is the next question that we asked. Right now, we are also doing one more study called KSHEMA, in which there are government has recruited social workers in 10 rural talukas, mostly in the north part of Karnataka. There is one social worker per taluk. Now, in collaboration with the government of Karnataka and National Health Mission, we are looking at comprehensive assessment of rehabilitation needs of patients who receive treatment in these centers. We have given mobile phones to the social workers, and we track the progress of provision of services, especially community-based services, through an app. So there is a software solution to monitor this, the KSHEMA app. The tablets have been provided to social workers. We have twice monthly online meetings with these 10 social workers, and where we discuss the progress about the rehabilitation part of the patients. This is how the app looks. The social worker logs in, he provides the details of the patient. Then you can see here in this slide that we can see if there are any pending for this patient, for example. This is a not real name. I'm just making it out here. I'm not revealing any patient's confidential data here. So the welfare module, there is one task remaining. The UDID provision, one task is remaining. Rest of the things they are up to date. So this is how it will help them to track the patients. We have had an opportunity to look at what happens to follow-up rate. 75% were in follow-up of the about 1,000 odd patients. In our opinion, 75% follow-up rate is excellent, because if you do not follow patients carefully, more than 50% drop out. So we looked at what happens to them in terms of their disability, symptoms, etc. And you can see here that again something similar to Thirthalli project. People who had remained untreated had high disability. People who took our treatment, which is comprehensive, had least disability. Patients who are receiving treatment elsewhere also were having significant disability, possibly because they are given only pharmacotherapy. They don't get any psychosocial interventions. This trend was true for clinical global impression, quality of life, and burden assessment. So in all domains, the patients who received significant psychosocial inputs from KSHEMA were better than patients who just received any treatment, and these people were better than untreated patients. When we looked at the qualitative interviews with these beneficiaries, they said proactive follow-up by the social worker led to low rates of relapse, comprehensive intervention vis-a-vis only medications, and free medications and consultation. People who are taking treatment elsewhere were paying for most of their consultation and medications. They said that getting free medication helped them in ensuring adherence and better outcome. Quickly about a couple of biological studies also that we have done. We have found that some geospatial aspects where people live can affect cognitive functions in general patients also, like whether you stay in an urban area, whether you live in a forest area. Some differences are found in cognitive processing and social cognition versus neurocognition. We wanted to study what happens to this in schizophrenia using Google Earth and visual mapping analysis. We have done some kind of study. This is the results of a patient who had significant green cover, a little bit of open public and very few built up area. This is the data from one single patient. We did this for all patients who lived in Thirthalli and Tiruvekere and Bengaluru from NIMHANS. What we found is that people living in environments which have higher build space and density and lower green cover had higher cognitive control but poorer social and reflective cognitive abilities. So altering the lived environmental characteristics based on these observations may have a therapeutic role in amelioration of cognitive dysfunction, albeit partially so. Very, very preliminary study, but very interesting to observe. We also looked at parental consanguinity using a DNA-based measurement of consanguinity. Whether patients with schizophrenia, their parents had higher rates of consanguinity or not. This is the question that we asked. What we found is that indeed so, significantly higher parental consanguinity was found in patients with schizophrenia, which suggests that multiple recessive risk alleles contributing to vulnerability. So this doesn't mean that we should discourage consanguineous marriages, because consanguineous marriages have other psychological, social, and other aspects of it. And what it shows is that in terms of biology, there seems to be some contribution of, recessive alleles in terms of causation of schizophrenia. To some extent, we are replicating what is fairly well known in some of the Arab countries, where consanguineous rates are very high. So the take-home message from my presentation today is that there are several findings about persons with schizophrenia in rural Karnataka which are unique to India and maybe to our own cohorts. Many of these are of practical and some heuristic importance as well. It takes a village to raise a child is an African proverb, and it takes a whole lot more to study life in villages. That's why I want to acknowledge a lot of people who have helped us in working in rural areas and also to come with some reasonable research output also. Thank you very much. There is one online directory which we have recently started. Just Google, please, NIMHANS RA. So please kind of register yourself. When you register yourself, you will be seen by the public. Your clinic timings, etc., can be seen in this. Please make use of this. Thank you very much.
So, good evening. As Dr. Jagadisha sir has already asked for no question after the presentation, we will directly go for the vote of thanks. I would like to thank the Tamil Nadu IPS office bearers, headed by Dr. Sabrin sir, for the constant encouragement for doing this program. I would like to thank our program coordinator, Dr. Nirmal sir, for successfully conducting this program. I would like to thank thank our presenter, Professor Dr. Jagadisha sir, for accepting this particular program. We had a lot of learning from you, sir. Our postgraduates as well as consultants actively participated and learned a lot from you. I would like to thank our postgraduate from Dhanalakshmi Srinivasa Medical College, Dr. Kirthana, for successful presentation. And I would like to thank our moderator, Dr. Vanishri ma'am, as well as Dr. Shivanand sir, for introducing the speakers, as well as being the moderator for these sessions. I thank all the postgraduates who have participated from various colleges in this program. I would like to thank the East West Pharma Christian team for provided us the technical support. Despite the fungal cyclone, everybody tried to be a part of it, and we would like to thank everybody. Thank you, sir. Thank you, Nadu. Thank you.